2022 meeting of the Commission on Race and Access to Opportunity to order. As a reminder, please silence your cell phones so they do not disrupt the meeting. Thank you to our lead staff member, Brandon White. This has been his first interim being our staffer, and this is our last meeting of the interim. And so if we could just give a round of applause to Brandon and Brett for the work that they've done for us this interim, we greatly appreciate it. They have helped us. They've helped us a lot in just making sure that the meetings are running smoothly, but also providing a lot of policy solutions along the way and recommendations. And so I'm very grateful, and I've enjoyed seeing Brandon more specifically grow in his transition from transportation to the commission. So very proud of both of you all. We went ahead and get started. As you can see, we do not have a quorum, so we're not going to be able to do any official business of approving the meeting minutes from last time. But we have such a long agenda today, I wanted to go ahead and get started. We're actually going to go a little bit out of order today on the agenda. And then once we do that, then we'll be back to regular programming. Do any members have any comments or recognitions before we get started? No? Okay. As a reminder, the commission purpose, the statement is in everyone's folder, but as we do every meeting, I would like to read that. And it says, the purpose of the commission shall be to conduct studies and research on issues where disparities may exist across the sectors of educational equity, child welfare, health, economic opportunity, juvenile justice, criminal justice, and any other sectors that are deemed irrelevant in an effort to identify areas of improvement in providing services and opportunities for minority communities. So let's go ahead and get started. We're actually going to do agenda item number 6, maternal health and doula access. So if Hope and Tabitha can come up to the table. And I believe your counterparts are on Zoom. Please introduce yourself for the record, which includes our our people on Zoom as well. And then you can go ahead and get started. And make sure the light is green on your microphone. It'll be a bright green, okay, so everyone can hear.
Okay, I will do that, and I will also pull up the PowerPoint. So, Co-Chair Heverin, Co-Chair Givens, thank you for having us here today. Hope McLaughlin, Elevance Health, members of the commission, glad to share some information with you here today. Oh, sorry. Did I do the wrong thing? Zoom. Okay. Now we're going here. A little technical difficulty or delay. So as I said, I'm Hope McLaughlin, and I'm the Senior Director of Government Relations for Kentucky for Elevance Health. I am joined online by April Falcone and Leah Ramirez with our Public Policy Institute, and here at the table by Tabitha Ross, who is the Health Equity Director for Anthem Blue Cross Blue Shield Medicaid in Kentucky. And we wanted to share some information with you here today about a report that the Public Policy Institute put together regarding addressing maternal health disparities and doula access in Medicaid. And with that, I'm going to turn it over to April to get us started.
Hello, my name is April Falcone. I'm Associate Research Director at the Elevance Health Public Policy Institute. Just a quick introduction to the Public Policy Institute. We were established to share data and insights to inform public policy and shape healthcare programs. We are a group of health policy and health services researchers, and we strive to be an objective and credible contributor to healthcare information and publication of policy relevant data analysis. Okay, so a little introduction about why we took on this research. As many of you may be familiar with, there's a maternal health crisis in the United States. Maternal mortality in the United States outranks every country in the developed world, and Black women and American Indian and Alaska Native women disproportionately experience this impact of this. They have a 2 to 3 times greater risk of dying during pregnancy compared with white women. Also, as access to obstetric care in rural areas continues to shrink due to hospital closures, Black women, once again, are disproportionately impacted. And if hopefully you can see in this chart here, on the right-hand side of the slide, maternal mortality has even just increased within the past couple of years. And you can see at these teal colored bars how the proportion for Black women is just so much higher than non-Hispanic white women or even Hispanic women. And I can tell you, just to put into context for Kentucky, that the rates for maternal mortality are even higher in Kentucky than they are for the United States. So it's a real pressing problem. Okay, next slide. Okay, so, a lot has been asked about what can be done because a lot of maternal morbidity and mortality is considered to be preventable. And one strategy that's been proposed is doulas. Doulas are not medically trained, but they are certified, and they work alongside clinical providers. They have a lot of services that they offer women and their families. They can offer reassurance and provide information and health education to women. They facilitate communication between mothers and providers. They're often situated in communities that they serve, so they share the same background and culture and language as their patients. And also, in rural settings, it can be a really big help because women often live very far away from the hospitals that they ultimately give birth at. So doulas really can be a great resource for helping rural families navigate the healthcare system. Okay, so a little bit an introduction to the research that we did. We evaluated a pilot program in California and New York, and then the doula program within Florida. And these are doula programs within Medicaid in these states. And the programs within California and New York, these programs were targeted at really women that were living in areas that have among the highest maternal and infant mortality in the states. These are areas where there's high segregation and poverty and unemployment. In California, the infant mortality rate is at the same level as it is in developing countries. And then just demographic differences. The women in these programs were either more likely Black or white, but not Asian or Hispanic. They were older, average age, maternal age at birth. They had a higher prevalence of pregnancy complications like preeclampsia and anemia. And I mention all of these factors just because traditionally doula care has only been reserved for people who can afford them. So often it's been people who are a little higher income, they're a little more wealthy. And so there's been this thought that maybe this research that has shown that doulas are this really great benefit to maternal health, maybe it's just because the women who are able to use them are just somehow healthier and better off. But in this situation, these women actually, at least for California, New York, and then the doula program for Florida was throughout the entire state, these women actually were at higher risk for many reasons due to their demographic characteristics, but also because of some clinical characteristics. Okay, next slide. But we saw really great results with our analysis. We saw that women who had doulas had a lower proportion of low birth weight infants and lower admissions to NICU, their infants. A higher proportion of women who used doulas carried their babies to term or post-term, and also a higher proportion attended their postnatal visit. This was a really great finding because so much, more than half, I think, of maternal morbidity and mortality occurs within that postpartum period. So having women attend their postnatal visit to make sure that their health is good is just a really great finding and can potentially have huge ramifications in terms of maternal morbidity and mortality. And we can see here on this chart, the last chart, in the blue and the teal bars here, these are women who use doulas, and we just broke it down by the different clinical combinations. And, regardless of the clinical combination, the women who use doulas had these, these higher proportions of postnatal visits and then the term and post-term births. Okay, next slide. And then we took it a step further, and we used a very rigorous statistical technique called propensity score matching. And just a brief summary of that is we do that was we match women who use the doula to those who didn't use a doula. And we match them on a lot of different characteristics, including state and age and race and area level socioeconomic status and hospital type, meaning is it like a research teaching hospital or not. And again, the point of this was really to make sure that the women who are using doulas did not somehow fundamentally differ from the women who didn't use doulas that could somehow affect the findings. Even after we did this statistical technique, women who used doulas had a 53% lower odds of having a cesarean delivery. And then even among the women who had pregnancy complications like preeclampsia, those sorts of conditions that would put them at higher risk anyway for a C-section, these women who use a doula had a lower odds of having a C-section. We also saw that women who used a doula had a 58% lower odds of postpartum depression or anxiety. This was amazing news to us as well, just because we know that postpartum depression and anxiety are one of the biggest maternal morbidities that women experience. And then lastly, we also saw that the allowed medical costs of pregnancy were less among women using doulas, and we suspect that's due to the lower odds of cesarean delivery. And then one more slide for me. I just wanted to say, my hypothesis going into this research was that women who use doulas, maybe would only be useful at delivery. That, the continuous labor support that doulas offer and the breathing techniques or whatever, that's where we would see the benefit. But actually, we saw that when women initiated their doula care within their first trimester, that is when they had the lowest odds of having a cesarean delivery. And this is controlling for this maternal comorbidity index. So this is adjusting for women's conditions like preeclampsia and anemia, and et cetera. Women who initiated their doula care in their second trimester also had a lower odds for cesarean delivery than the women who just used it at delivery. So the purpose of this finding is just to show that women who initiate their doula care earlier and establish that relationship with the doula are really getting the best bang for their buck in terms of getting realizing the benefits of having this doula care. So starting it earlier, the better. Thank you.
Tabitha Ross, Health Equity Director for Anthem Medicaid of Kentucky. One of Anthem's goals in increasing prenatal care in Kentucky was one of our most important goals. So when we heard about the impact that doulas were having across the nation, we wanted to take a look at that a little bit further. And so we invested in doula scholarships here in the Kentucky market. And the hopes of that and the goal was to improve outcomes of our moms and babies across the state. So what we did was we partnered with 3 doula agencies and organizations. So Mama to Mama, Kentucky Doulas, and Hope's Embrace. All of those were provided scholarships across Jefferson, Fayette, and 28 additional counties across both serving in urban and rural communities. 3 agencies, of those 3 agencies, they hired 25, now actually I think it's changed since this slide was created, 26 doulas of diverse backgrounds. One of the pieces of the program is to ensure that they had cultural concordance, recognizing that there was importance of representation in the relationship between the doulas and the mothers. So they were mindful to make sure that they were hiring diverse racial, urban, rural language backgrounds, as well as engaging an ASL certified doula. Those 3 agencies have provided 87, and I think most recently we saw it was 99, birth scholarships across the state, of which we saw similar outcomes of birth in their programs, reducing the C-section rate by 65%, 85% reduction in behavioral health diagnosis such as postpartum anxiety and depression, as well as a 96% increase in breastfeeding rate. They also have had a total of 146.5 hours of lactation support to those mothers that they were providing services to. In addition to that, because we saw those positive results with those 3 agencies, Anthem has further invested in supporting an additional agency, My Sunshine Birth Services, to provide for women in rural Kentucky. I think they're going to be primarily located in the Warren County region, all of which are helping Anthem's goals to increase prenatal care and improve the health outcomes for both moms and babies across the state of Kentucky.
Hi, Leah Ramirez, Health Policy Director with Elevance Health Public Policy Institute. So I'm just going to be going over some Medicaid policy options and considerations. And, one of the reasons that Medicaid is the focus is, first of all, that's what our study focused on. But also, if you think about kind of the landscape in Kentucky, Kentucky Medicaid actually covers approximately half of all of your births in the state. And we know that women who are insured by Medicaid do have those disproportionate maternal health outcomes, as it relates to maternal mortality and morbidity. So that'll be the focus today. And with these policy options, I just want to level set for those in the room that may not be very familiar with Medicaid programs, because it's sort of important to remember as we talk through these. Medicaid is a state-federal partnership, meaning that state Medicaid programs, including Kentucky, sort of has agreements with the federal government on how they will administer their Medicaid programs. And that's important because then the federal government then helps partially fund Medicaid programs within the states. And so that's why states have to adhere to these different kind of federal authorities and regulations is in order to get that federal funding for those services. So the first policy option is called a state plan amendment. And again, all states have a state plan as it relates to their Medicaid program that is basically the roadmap for who they deliver services to, what services they offer to their members, et cetera. And so states can go this route and basically submit an amendment to the federal government and say, we want to pay for doula services and be able to reimburse for that. One of the caveats to that through this route, however, is that doula services would have to be recommended by a physician or another licensed practitioner, which is usually defined in state's admin code or law. The second pathway is through what's called a Section 1115 demonstration waiver. And again, waivers are essentially the states, again, going back to the federal government saying, we want to waive a certain part of the Social Security Act as it relates to Medicaid to be able to, maybe do something innovative or maybe limit services to a certain area or to a certain population. So there's a lot of flexibility in this pathway because states can, again, really design it how they like, or maybe if they don't want to have to get a kind of a prescription from physicians or licensed practitioners, this would be a good option. And then third, and fourth are kind of related, but third are through managed care organization contracts or MCO contracts. So Kentucky's Medicaid program, again, contracts with MCOs to, manage the care of their Medicaid members. And so states can really use contracts to promote the uptake of doulas in their programs. So just thinking about all the great work that Hope and Tabitha and their health plan have been doing in the doula space, Medicaid agencies could somehow take that back to their Medicaid contracts and perhaps design things for all of their health plans to do something in a similar regard, again, to help, increase the workforce or train the workforce, whatever they see fit and feasible for them. And then fourth is through quality initiatives. So again, the federal government requires all state Medicaid programs to have quality strategies. And within those quality strategies, there's different initiatives that are also carried out through their contracts with their managed care organizations. So some quality initiatives do focus on maternal health outcomes. And within that, again, using doulas or piloting doulas in different areas or for a specific portion of your women who are pregnant is again another pathway for states to figure out how to reimburse for doula services. And next slide, thank you. As states kind of, take into consideration for integrating doulas within their programs, there's sort of several different things to keep in mind. And, this says integrating community-based doulas because just kind of remember that the population that doulas would be serving within the Medicaid space is different than, women who traditionally use doulas during birth, women who are paying cash and have the resources to be able to do that. So first, just kind of remembering reimbursement models. One of the lessons learned from other states that have, again, integrated doulas within their Medicaid programs is that they need to be reimbursed at a rate that is a living wage for them. Remembering that, they may be spending a lot of time with women during the prenatal period, birth, and then the postpartum period. And you don't want to create barriers for doulas to want to participate within the Medicaid program and want to be providers. The second is around partnerships. And personally, I probably think this is maybe one of the most important, because you want to be engaging, doula organizations and other stakeholders very early on in the process. And that includes your Medicaid MCOs, so that you can think about, again, how designing a benefit would work within Kentucky Medicaid, and also thinking about and learning what supports, again, doulas may need as they consider becoming a Medicaid provider, whether it's infrastructure or training around Medicaid billing policies, et cetera. And then third is just the workforce strategy. So I already mentioned that, the population that these doulas would be serving is different than a traditional doula. And so going beyond that training to think about, equity and cultural competency and humility, trauma-informed approaches, but also training them on the knowledge of different resources within women's community. If you think about, again, if a woman is thinking about childcare for their baby once they're born, how can they find affordable and quality childcare? Or if you think about the postpartum period, if they're trying to breastfeed and are having a hard time, how they could potentially get connected to formula or lactation support. So a doula could really be that person to support the women during, again, that entire period. And then last is just scope of services. So again, thinking about how early on in the pregnancy your Medicaid program could start reimbursing for services. And then also how long during the postpartum phase, you would like to see doulas support those women. Our research has, as April mentioned, shows that earlier engagement led to lower odds of C-section. So again, just using that evidence to inform the programs that you may be designing. Next slide, please. So just some key takeaways to wrap us up. Again, doulas can really be that person to provide the person-centered care to women who are pregnant, to address disparities, to increase supports for them. Our data shows that women using doulas in Medicaid are more likely to attend their visits. They experience lower odds of C-section, postpartum depression, anxiety, and lower total medical costs. So really reimbursing for doula services within Medicaid, as we think of a larger maternal health strategy, is just kind of one tool within our toolbox. Next slide. And then we just want to leave you with some resources, to look at in the future. So the first two are our specific Elevance Health briefs and publications that we have, and then just some other resources too on what other states have done, and just some more information on the considerations that I just sort of touched the surface level at today. And with that, I just want to thank you for the opportunity to present, and I will turn it back over to the committee.
If you have any questions, we're happy to answer anything that the commission has.
Do members have any questions? Representative Kulkarni?
Thank you, Madam Chair. I think that's the right designation. I can never get it right. Thank you. Thank you. I think I had a question for Ms. Ramirez, who mentioned MCOs a couple of times in her presentation. I'm not familiar with, these models enough to speak intelligently about them. So I was just wondering if you could explain a little bit about what it looks like on that slide where you were talking about Medicaid policy options. States can use their MCO contracts to promote the uptake of doulas. What does that look like on a practical level?
Yeah, thank you for the question. So, again, all state Medicaid programs that utilize managed care, meaning that they, again, contract with MCOs to really manage people's care, not just pregnant people. But they, there's different ways that they could do this, that other states have done this. So one strategy could be if you want to require MCOs to offer training to doulas within the Medicaid program. So again, around that cultural competency or humility, there's a lot of different trainings that you could do. Another route that I mentioned are quality initiatives. So some states will use their managed care quality initiatives to require their MCOs to implement a doula pilot. Sometimes if there's multiple MCOs, which there usually are within states serving your Medicaid members, they may require MCOs to focus on different areas of the state for their pilots. So one might be, and I'm not super familiar with Kentucky, but might be Western Kentucky. Another might be Eastern Kentucky. They might require another MCO to do a rural area or an urban area. So those are just practical ways that other states have used their contracts to, again, support and promote doula services.
Thank you.
Representative Dimony.
Thank you, Madam Chair. This is a topic that I've spent a lot of time thinking about, and it's just the reports and the numbers. It's just not good. The numbers are just aren't good. I have several questions, Madam Chair. They're not very lengthy, and some of them will probably be pretty brief. But yes, ma'am. First, why are our numbers so bad? This is the United States of America. We have outstanding medical care. Why are our numbers lower than third world countries in this particular category?
April or Leah, do you have any insight into that?
Yeah, the answer is we don't know, especially for Black women. We know that this disparity still exists even for Black women who are highly educated and have high income. There's certainly been lots of maternal health commissions that will examine every single maternal mortality that occurs within the state, and then getting into that and figuring out what the causes are so that they can ultimately reduce maternal mortality. Those sorts of commissions have been effective, but we still have this ongoing problem. It does seem like there is an issue of, I can say, just from my own research, because likewise, I've also spent a lot of time in this area, that it seems like there is some issue of coordination among providers, and there's just so many people, and the patient as well. There's just so many people who are involved, in this not in a physical way, but in a figurative way, touching the woman in her journey through pregnancy and postpartum. It's just, that are being expressed to get lost in the shuffle of everything. Having someone like a patient advocate or someone who can facilitate communication, such as a doula, for example, would be a great resource. This is
The beauty of technology.
Yeah.
I know I'm literally hanging in the balance here. Wait.
I think for the sake of time, Hope, we will connect Representative Timony with you.
Sure.
If you want to provide any additional comments, you would be welcome to.
Thank you.
With questions, but if we could just get some follow-up, I think that might be best for time's sake, since we have such a full agenda today.
Sure, absolutely. Happy to talk more about it.
Thank you.
Do you have any additional comments, Representative?
With this particular topic, and this is going to be a very specific question. As I heard the description, as we were talking about different things, we're talking about before the baby's born, delivery, and then post. Where are we seeing the highest? Which one of those three are we seeing the most significant issues?
There's a lot of issues. I apologize. I just heard I was breaking up in the last question. The evidence suggests that more than half of maternal mortalities and morbidities are occurring in the postpartum period. So I think that women are often, they're attending their prenatal visits. Most of them are. They're getting seen then. Once they deliver the baby, the rates of women who are attending any of their postnatal visits drops precipitously. babies are going to their well check visits, but women aren't getting the care anymore. So my personal opinion is that there is a huge issue with the postpartum period, that women aren't getting seen and their care is not being, continued.
Thank you.
Thank you. This is an issue near and dear to my heart, and so I greatly appreciate you all taking the time to come present today. So thank you all so much. We greatly appreciate you. If we have any additional follow-ups, we'll make sure to email that over.
Thank you.
Thank you.
Thank you.
Thank you.
Back to regular programming, I do need to ask Brett to take roll call since we now have a quorum.
Senator Berg, Senator Neal, Senator Westerfield, Representative Brown, Representative Kulkarni, Representative Timoney, Mr. Davis, Ms. Drake, Dr. Jones, Dr. Oleka,
Here.
Mr. Roberts, here. Chair Gibbons, Chair Heverin.
Present. Thank you. And then I need a motion to accept minutes from the last meeting. Okay. Motion is second. Okay. All in favor say aye. All opposed. Okay. Motion or minutes have been passed. Sorry, I kind of forget sometimes. Minutes passed. Woohoo! Okay, so next up we have, I'd like to invite Representative Keturah Huron and Dr. Brown and Dr. Williams to come up to the table. As you all can tell, today we've been discussing and we'll continue to discuss health and health outcomes. And we're also going to receive a demographic update from the Kentucky Center of Statistics. So kind of a catch-all, but really some really great information as we finish out this commission during the interim. All right. Please introduce yourself for the record and make sure your microphone is on.
Thank you, Chairwoman Heverin, for having me. I am Representative Keturah Huron, and I represent the 42nd District here in Louisville. And I will say that thank you, Brandon, as well, for your all of your help and support. I will say that you all have a great staffer, as he has been very helpful to me, as this is the first committee that I've had a chance to present in front of as an elected. And so thank you for that. I do have Dr. Sabrina Brown with me today, and then also Dr. Monique Williams. And once they speak, I will let them do a deeper dive and introduction into themselves. And so when I decided to run for office, I immediately said that one of my priorities would be to figure out ways to change and impact the gun violence issue that we have across the state and our Commonwealth. And before we get too much deeper, I know that anytime you say gun violence, people get scared. They think that you're talking about taking guns away. I do want to make known for the record, I do fully support the Second Amendment, and I am a legal gun owner. So I just want folks to know and understand that. However, my analysis of gun violence has changed and shifted throughout the years. I've had a lot of young people in which I've worked with who have lost their lives to gun violence. I've also had a lot of young people who have been perpetrators of gun violence. And then very personally, I had a 20-year-old cousin who committed suicide and took his life using a gun. And I also have a cousin who was doing federal time in the penitentiary for his role in conspiracy to commit murder, where 2 people's lives were taken. And those 2 people were folks that our families were close with. And so I feel like that this issue was very vast and it's broad. It's not black and white. And Chairwoman, I know that just in your district last week, there was an issue at an elementary school where a father was going to pick up his kids and he was running in the hallway and a gun discharged and he was shot in the leg, was hit in the leg. And so to me, in my opinion, that is also a form of gun violence. You have someone who is a legal gun owner who is very aware of the laws that you should not have a gun on school property. But I look at that as gun violence as the impact that that's going to have on those folks who are present. and then also the impact that it's going to have on the community. And so I have I'd filed before, and I'm working on a bill to create an Office of Gun Violence Prevention. And basically what this would do, it would change KRS section 194A 030 to create the Office of Gun Violence Prevention. And this would be placed in the Office of Public Health. This office would have an executive director, which would be appointed by the secretary with the approval of the governor. The office would also collect and disseminate data and make recommendations related to gun violence policy, community-based gun violence intervention and prevention programs. And for those who are familiar with the Office of Drug Policy Control, it would have the very similar same role as that office would have. Also, this office would be in charge in getting alternative funding sources other than state funds to make sure that this office runs properly. And we know that in June, the Bipartisan Safer Communities Act was passed at the federal level. And there's about 7 to 9 different categories in that piece of legislation that would allow us from the state to be able to get funds and resources. And some of that is going to be for violence intervention programs. And then some of it is going to be for family and mental health services. There's also parts in that federal legislation that would allow violence-based traumatic events, so support for those. And then it would also allow support.
Research Center, known as KIPRIC, was established in 1994, and it's a unique partnership between the Kentucky Department of Public Health and the University of Kentucky College of Public Health. It serves as both an academic injury prevention research center and as the bona fide agent for statewide injury prevention and control. And we focus on injury prevention, translation, but also practice and community-based services. So I've been the principal investigator for the Kentucky Violent Death Reporting System since 2004. This system is part of the national system that includes all states and territories. As part of the National Violent Death Reporting System, we enter death certificates and death scene investigation reports into the system. Deaths include homicides, suicides, and all gun-related fatalities. And I just want to add that during the interim, about a 10-year period where there was no gun research, this system continued through that time. So we're really the only entity during that time that continued to collect information on gun-related fatalities. I'm just going to get a little bit of water here. Now I'm going to put a lot of numbers out there and data. I don't have slides, but I'm happy to provide anything that you need prior or after this talk today, anything that you need to follow up with. So I'll try not to overwhelm you and talk too fast with all the data. And also, just to let you know, we have a lot of data sets at KIPRIC. And so we have different years that are available. So anywhere from our latest year is 2019 to right the current quarter. So it varies between the data years. Just want to add that. So according to the Centers for Disease Control and Prevention, there were almost 40,000 firearm-related deaths in the United States in 2019, and 109 people died from guns every day. 6 out of every 10 deaths in 2019 were firearm-related suicides. More than 3 out of every 10 were firearm-related homicides. And we hear a lot about the homicides and the shootings, but what is not talked about a lot are the suicides, and that's much more prevalent are the suicide firearm-related fatalities. And there's an unwritten precedent in the media to not report on suicides because there is an evidence base that there are copycats when suicides are reported on in the media. So it's kind of, do we report on it or not? Because if we do, we raise awareness, but if we do, then there also is the potential of copycats and clusters. So nationally in 2020, there were 19,384 homicides, and the average cost to each homicide in the United States was over $9,000 for each homicide. There were over 24,000 suicides in the United States. The average cost for each suicide is over $4,000 in the United States. In Kentucky, in 2020, just 1 year, 341 homicides. The average cost was nearly $8,000 per homicide. There were 518 suicides with over $4,000 for each suicide. So it's a great cost to us as well. If you look at the 10 leading causes of death in the United States, the ages of 1 to 44, suicide and homicide are the top 4 leading causes of death. And as you can see, I don't have a slide, but I can provide this information. These are the 10 top leading causes of death. But we see homicide and suicide all over the leading causes of death. If you look at potential years lost, if you think of 65 as the year that is the goal to arrive at, as an individual, the years of potential lost in Kentucky for 2020 is over 21,000 years of potential years lost. And we always want to look at the children, what's going on with our children in Kentucky. If you look at unintentional firearm injuries in our children, an average of 19 emergency department visits for unintentional firearm injuries occurred per year among Kentucky youth from 2016 to 2021. The median cost for emergency department visits for that same time period, 2016 to 2021, was over $2,000. What's interesting, if you look at the children and you look at the ages, if you look at under 5 for unintentional firearm injuries, 34%. Ages 5 to 7, 31%. And ages 8 to 10, 35%. So it's pretty equally distributed among the ages of our youth and children. Females, 28%, and males, 72%. It's pretty well distributed, pretty equally between metro and non-metro areas for children with unintentional firearm injuries. Metros, 52%, and non-metro, 48%. Of all unintentional firearm injury emergency department visits involving youth from the same years, 2016 to 2021, 116, 72% were male, 72% were white, and 52% were from metro areas. The body regions of the unintentional injuries: head and neck, 28%, torso, 22%, extremities, 50%. Another concern that we have with firearm injuries is intimate partner violence. And we see an increase in intimate partner violence with males, a decrease in females with intimate partner violence related suicides with a firearm between 2005 and 2020. But intimate partner violence related homicides with a firearm, it increases for the females and it increases for the males between that time period. I know you can't see this, but if you look, the trend lines are going up. In homicides, suicides, you can see the males are going up significantly, but both are going up with the homicides. And just a caveat, during 2020, during COVID, because we're a bona fide agent with the state health department, we monitored suicides very closely because there was the perception that suicides were going to go up because of all the risk factors, isolation, those sorts of things. We found that suicides initially went down during COVID, and then we saw a cluster of homicides followed by suicides. And then we realized that the suicides were going to start going up, and they sure did. Because homicides followed by suicides are almost always domestic violence related. And I just want to have some other statistics. Over the last 20 years, rural areas have seen an increase in suicide by firearm by 1.4 times higher than urban areas. 79% of Kentucky's veteran suicides in 2020 were by firearm, compared to almost 65% of overall Kentucky suicides. In 2019, actually, we were funded with the Kentucky Violent Death Reporting System starting in 2004. Since 2004, We now have 2020 data. During that whole time, Kentucky has a higher rate of firearm fatalities than any of the other NVDRS states combined, the rest of the National Violent Death Reporting System combined. So since 2004, we always have a higher rate of firearm violent death. And that's both with our females and our males. The age where it's most prevalent, 45 to 54, we have the most firearm fatalities, and males outnumber females about 3 to 1. And I think that's all I have. If you have any questions about the data, I'm happy to field those questions.
We'll go ahead and finish the presentation, then open up for questions.
All right. Dr. Monique Williams, I'm an assistant professor in the School of Public Health and Information Sciences at the University of Louisville, where I study violence prevention. And I was asked to kind of talk about gun violence from a public health perspective. And I think that when it comes to gun violence, I think the year 2020 and the pandemic provided an unfortunate unveiling of just how much of a public health issue violence is and how critical it is for us to talk about it from that lens. You know, thanks to the pandemic, we had cities across our state and nationally that were impacted by economic crisis, different varying levels of social disorganization that was happening due to the isolation requirements to keep us safe from COVID-19. Lots of people had limited access to resources that they were normally used to being able to access. We had increased trauma and traumatic experiences for many people for various reasons. School closings, we had safe recreational spaces for young people closing. All of these, you had a question? Okay, sorry. Okay. You know, all of these things had an impact on health, both physically and mentally, but it also had an impact on our violence outcomes. And we couple that with kind of record purchasing of firearms in the year of 2020, where, you know, it's estimated that about 22 million firearms were purchased in 2020, which was a 64% increase from 2019. And what we saw in 2020 was kind of a shift in even our, well, for children ages 1 to 19, the leading cause of death for decades has just been motor vehicle accidents. And in 2020, that shifted to firearm-related death. And that's kind of where we are now with the leading cause of death for our children ages 1 to 19 being firearm-related. On top of that, we know that, you know, guns are the most chosen weapon when we talk about homicide and suicide. In fact, for suicide, it's the leading method. And I think the death rate for those who utilize guns for suicide is about 85% in comparison to about 3% for other suicide form attempts like drug overdose. And so that becomes significant when you know that 90% of individuals who survive a suicide attempt don't try again. And then, of course, when we look at our homicides nationally, 75% of homicides involve guns nationally, and we know that it disproportionately affects our Black and brown youth in our most racially and economically deprived communities. So we know we have an issue of gun violence on our hands, and we know that there are multiple risk factors for violence that increase its likelihood. And it's a combination of individual, relational, community, and societal factors that contribute to it. However, there are many factors that we know that protect against violence happening, and a lot of those protective factors were disrupted during the pandemic. And so where you had disruption in areas that weren't used to these kinds of disruptions, you know, you saw violence begin to happen in some spaces, and then you had the spaces where kind of the fires of violence were already there and you just poured gasoline on that fire. And these were the places that were already struggling from economic deprivation. These are the spaces that are already struggling with, isolation and social disorganization of neighborhoods, already struggling with trauma and mental illnesses that are not addressed and have limited access to being able to address those things. Areas where access to safe recreational spaces for young people are already limited. So when we talk about how we experience violence, it's really important that we're paying attention to our risk and protective factors. And the fact that gun violence has all of these risk factors, we know that it's preventable. And so when we look in public health and when we're looking at implications of whether or not something is a public health issue, we're looking at whether or not there are preventable risk factors. We're looking at whether or not there are physical and mental effects of the issue. And you look at gun violence and the answer to that is yes. You look at whether or not there is morbidity and mortality associated with the issue, which is just, is there illness and death associated with the issue? The answer to that is yes. Are there health disparities associated with the issue? The answer is yes. And are there substantial health care costs associated with the issue? And that answer is yes. So for lots of reasons, we know that this is a public health issue and it needs to be addressed from a public health lens. The research and our best practices tell us the same thing. And so there's kind of more than enough local and national evidence to tell us what we're dealing with. It's just shifting probably an ideology and how we think about violence for us to better address in the ways that we know that we need to be addressing. And right now we don't necessarily have the best system for violence prevention. We've relied heavily on one system that was not created to address risks of violence, nor was it created to build resilience or protective factors against the likelihood of violence happening. Our kind of criminal justice and law enforcement systems are overwhelmed with parts of violence that they were never meant to address. Especially with our criminal justice system. I mean, it's just that. It's meant to address criminalistic activities and behaviors, including violence, but that's after something has happened. Through research, we know that violence is not inevitable and it is preventable, and utilizing public health systems and approaches allows for us to do true prevention, and it allows for us to kind of create the systems that are where we're able to engage multiple sectors. Right? The best strategies for violence prevention are comprehensive because it's a complex issue. And that's a lot of times where people get frustrated because we want answers now. But the best way to get to results is to take the time to build the infrastructures necessary to make the systems that all touch violence work together to address the issue in the ways in which we know it needs to be addressed. And so we have to look at the downstream factors, the kind of individual factors that hit the direct violence that we see that everybody is kind of concerned about, whether you're talking about suicide, homicide, domestic violence, child abuse, elder abuse, all of those kinds of violence are considered direct violence, and that's what everybody sees and everybody pays attention to. But there are upstream factors and systemic factors that play into creating the conditions for that type of violence to be more likely in the first place. And so it's not an either or, it's a both and you have to build a system that addresses the both and for us to get the results that we're saying that we want to see. And so public health approaches allows for us to kind of do that. And it allows for us to treat violence like the disease that it is, as we see it becoming an epidemic in our society. And it would be beneficial to have a coordinated operating body that can do what public health does, which is to engage in kind of the core activities of monitoring and surveilling so that we can define what the problem is, particularly in our local context, identifying and assessing what risk factors affect how we are seeing violence in our particular spaces, and then what protective factors are in place, but also being able to identify where our gaps are. And then from there, helping us to kind of either kind of support the development and or identification and implementation of interventions that decrease these risk factors and kind of build community resilience. And then lastly, evaluating our efforts so that we know what works, and we can tweak what we need to tweak, where we need to tweak it. But then also, it would also help us to kind of institutionalize what we know works. And so public health has offered a lot to violence prevention over about 3 decades. And so from a theoretical perspective and research, we kind of know, but it's hard in practice to make transitions, but we do indeed need to make those transitions, and really help everybody understand that the same social determinants of health, those things that help us know whether or not we're healthy, when those things are impacted, they also impact the ways in which our communities experience varying levels of violence. And so it's bigger than a criminal justice issue, it's bigger than a law enforcement issue. It really is a health issue that requires a health approach.
Thank you. Okay, are we ready for questions? Yes. Okay. What a thought-provoking conversation. We always say, Senator Givens and I, we say we're here for the hard conversations. And I think a lot of times when I think of gun violence, I think about it being a Louisville issue or an urban issue. But Keturah, you framed it in a very interesting way of this is a Kentucky issue. This is something, what we might not think is gun violence in rural Kentucky is still could be considered gun violence through a specific definition. And so it's my brain is going everywhere, I think, right now. I want to commend Representative Herron. You've done a fantastic, and I just shared this with you before. We've known Keturah as an activist, and she is now a policymaker. And so taking what she's learned actually in Louisville and her district and her area that she's so advocated for, even across the Commonwealth, you've now brought that into a different light. And so I just want to commend you and say I'm very proud of you as a colleague for making that transition and continuing to learn and do that smoothly. So I will open up for questions. I believe that Senator Neal is the first one on our list.
Thank you, Madam Chair. And thank you, Representative Herron, for bringing this issue up. It's not something immediately to our attention because it's all around us, of course. But thank you very much, because what it appears that you're offering and you're putting on the table is a ability to focus in on and grapple with and perhaps come up with some solutions, societal and individual solutions that will benefit us all. So I want to commend you on that. Thank you. I want to commend the others that provide the information here today. We appreciate that. In fact, I'd like to have some of that statistical information, if you can provide that to the chair or staff. I'd really like to get a hold of that. I did want to ask a couple of quick questions. One, although it's been framed as a Kentucky issue, which I agree, there are components of it, and I was very interested, and I think I heard, and I'm not sure, did you have a breakdown of the manifestation of violence from an urban and rural perspective on a percentage basis? Did you provide that?
Let me just check. I mean, I do have that. I can provide.
Could you share that?
Yes. Definitely. We look at that all the time, the difference between urban and rural. What's interesting, I will let you know, so in the rural areas, there's more suicides, and the urbans used to be more homicide, but now that's kind of changed. Homicides are more universal across the state, more than they used to be since 2020. But we definitely will get you that information.
So, you don't have it here, the breakdown, but you can get that.
Oh, yeah.
I'd appreciate that. And if I have one more question, please.
Yes, and please make sure to turn on your mic when you speak, just so everyone can hear. Thank you.
I'm just going to go ahead and turn it on and just leave it on.
That's perfect. Go ahead, Senator.
Thank you so very much. With respect to children and the violence, you put them in a framework referred to as unintentional. I guess that's the same thing as accidental. Is
Yes.
that correct? I had some legislation that dealt with just firearms being in the home and not being secure. and being accessed by children. No one intends anyone to get hurt, but because of how it's handled, some young people have been injured as a result. Would that be part of your investigation? Is that anticipated to be part of the investigation of this, for lack of a better term, commission that would be looking at this?
Yeah, that's a good question. I think that you're referring to, is this the Baby Dre Act?
I'm not sure.
Okay, okay. But yeah, I think that the goal is for this office is to really dig down into what the issues are and then give those policy recommendations as well. And so one of the things that I've noticed with, and I'm not sure if this is particular with that bill that you're speaking on, but some of the other pieces of legislation that looks at issues related to guns, gun safety, is that some of those bills just look at legal gun ownership, and it doesn't necessarily impact the illegal gun ownership. I don't know if that's ownership, they got them, so it is ownership. And so, this office would, once that data starts rolling, to look at what are going to be the best policy solutions moving forward. But I do want to make clear to folks is that no matter what, if someone is a legal gun owner and there's an incident or an accident in their house because they don't secure their guns, or if a gun is not secured in a car and someone steals that, we will never be able to arrest or criminalize our way out of the issue of gun violence. And so I want to be very careful and clear with creating more criminal codes or more penalties. Obviously, I do think that there needs to be some consequences for that. But I do think that that this office would then be able to help identify what are going to be our best solutions moving forward.
Just an observation, if I may. There's always this strange dynamic that takes place when you raise a question about guns. Mm-hmm. And when you try to deal with issues such as safety or something of this nature, then there seems to be a defensiveness on those who say they want to maintain the, I guess for lack of better words, the ability to maintain and have guns. Is this going to be part of the approach is to clarify what this means to us societally? Because it seems like it gets to a point of discussion and then discussion evaporates, rationality evaporates when you start talking about guns.
Right. I think that you're exactly right. And the one thing about this piece of policy, it does not say anywhere about taking guns away or raising the age or doing anything like that. It is clearly to say that we're going to create an office. I want it to be very clear that this office will be very similar to what the Office of Drug Policy Control does. Is for us to just identify and look at what we're seeing in our state, and then for us to come up with solutions. And I think that based on different jurisdictions, we may come up with different things. And so that's the goal of this, and I will continue to be very clear about that. But I think that you're right, Senator, is that when we start, even when you look at the agenda that is there, if you notice on the agenda, it says gun injury prevention. And that was done intentionally because of the fear of if we said gun violence, that people would have an issue and want it to be off the agenda. But the bill is to create an Office of Gun Violence Prevention, and that is what we'll do. And I think the one thing that we have learned, especially in this commission, is that if we're not very intentional in what it is that we're speaking about and talking about, then we're not going to address the issue.
Thank you very much.
Thank you.
Representative Kulkarni?
Thank you, Madam Chair, and thank everybody for presenting. It was a lot of really great information, really important information, and I think very much in keeping with the spirit of this commission in terms of trying to come up with data-driven solutions for these problems. I have a few questions, just two, if that's okay, Madam Chair. The first, I think is it Dr. Brown?
Mm-hmm.
Yeah. You had mentioned that 60% of it was gun injuries, I believe, or was it gun deaths? I wasn't clear on the breakdown. 60% from suicide, and I wondered if you could give me And you can also, this might be part of the follow-up that you provide to our committee members, just the breakdown of actual deaths resulting from, as opposed to injuries, the breakdown for suicide, homicide, and then accidental. And then I believe, Dr. Williams, you mentioned that 90% of those that attempt suicide do not try again if they survive that first attempt. Is that correct? That is an astonishing number, given that you also said that, 83% of suicide attempts with a gun are successful
85, yes.
the first time. So, I mean, this is a important, I think, piece of data to study. And then Representative Herron, I think I had a question about other states or other models that have tried this approach in establishing an Office of Gun Violence, Gun Injury Prevention. What are the best models out there in other states, and what kind of data, if you have any idea, this may not be available, what kind of trends have they found in terms of addressing this epidemic in their own jurisdictions?
Yeah, thank you for asking that question. I'm honestly not sure what other states have done it. I know that other cities have done it, but I want us in Kentucky to be a leader in that, to ensure that we are doing that. We do know that the Bipartisan Safer Communities Act did pass in June, and there is funding available to create such office like this. And so it is my hopes and goals that we are in the top states to do that and lead and become that model. And so I'm not sure exactly what those states are, but I can do a little bit more research and find out what that is.
And we're part of the National Violent Death Reporting System and have been so since 2004. So we're one of the older states. The system started in 2002. And so we have a lot of years of data, and we're able to collect that and get that information to you, look at trends with firearm versus non-firearm. And most are firearm.
Sorry, is that Kentucky specific that you have? Okay, perfect.
So we're part of the national system, the
and
Kentucky
we're one of the
Violent Death
oldest
Reporting
for
System.
that.
Yeah.
Got it. Thank you.
And we've been since 2004.
Okay. Senator Berg?
Thank you, Chairwoman. First of all, thank you all for this presentation. Thank you all for the bill. You know, this is something that is extraordinarily near and dear to my heart because unfortunately I live this. I see this at the hospital. For over close to 35 years now, I've been able to watch these trends, and we are in a place now in this state that we have never, ever, ever been before. I can promise you that. Couple of comments I want to make is that we just came off of an election campaign, and I can tell you that public violence is a number one issue for constituents in my district. Choice and control violence are the two things that people are asking me to do. And without acknowledging that you have a problem and exploring the problem, it is extraordinarily difficult to figure out what's going to impact the problem. So I would say this, commission has, or this office has, my 100% support, because until we understand what's bringing this forward, what's precipitating this, what can we do to address it, we're helpless. We don't have a way of addressing this without that data. I also want to add that states with basic common sense gun legislation statistically have less gun deaths and spend less on gun costs than states like Kentucky that basically have none of the 5 basic regulatory rules that the majority of other states have already instituted. Safe storage, basic legislation. So just want to say I really appreciate the work that you all have already done, the knowledge that you come in with, and I think this is a way for us to try to move forward as a state, acknowledging that we have an issue exploring the issue, understanding the depths of the issue, the costs of the issues, and then hopefully what can we do to start impacting this. So I just want to say thank you. I also want to add just one other statistic, simply because I heard it last night nationally. Nationally, the number of teenagers under 18 showing up in emergency rooms for suicidal ideation has increased 50% over the last year. I mean, we are going into an absolute crisis. And if these children have guns available to them, we know, and you've just testified, that their ability to execute a suicide successfully goes up tremendously. So if these national numbers are going to hold in Kentucky, guys, we've got to start thinking, what are we going to be facing in the next year or two here with youth suicides, which is going, we think we're expecting a huge uptick. So thank you.
Dr. Oleka?
Thank you, Madam Chair. Thank you, Representative Herron, for being here. It's always good to see you. Thank you as well to your colleagues for the data presentation. That is what my questions, if I may have got a few to try to move quickly here, that's what my questions are about, the data. Particularly the NVDR data. Have those data been controlled at all for income or geography or any of those factors?
Yes, we look at a myriad of other information, demographic, and then circumstantial, which is unique to the system. Mm-hmm. It's the first time that precipitating circumstantial information has ever been collected. So we look at financial to like crisis, disclosed intent, left a suicide note, a myriad of different circumstances.
Thank you. And then secondly, for those data or any other data that were cited, we talked earlier about illegal gun activity. Is that included? As in the individual who uses a gun for violence and how they obtained that gun, was it legally or illegally? Do we have those data included in what was discussed today?
So we rely on the death scene investigators for that information. If the coroner is the chief death scene investigator, but also law enforcement will investigate as well. So we rely on the narratives to tell us where the gun was stored or who was the owner. So sometimes we get that information, but sometimes we don't. But we do collect it if we do learn that it was illegally obtained. We do have that information.
Thank you. Then my third and final question, Madam Chair, if I may, it gets to, I think, some of the broader comments that were discussed before in terms of the data. Representative Herron, you mentioned that you were pro Second Amendment, so am I. Some of my questions and concerns about this regard to how the data was presented in terms of the root causes, if I may, in terms of how this violence is perpetrated. We talked about homicide, suicide, those numbers particularly going up post COVID lockdown policy. That was government policy that then led people into a different state of mind, a psychological change, a psychological shift. We talked also about how there are environmental factors. Again, if you are in a particular community that struggles with a number of different things, whether it was psychological trauma from some event that occurred, whether it was historical, generational trauma in your small rural area or in an urban community, there seem to be other factors that contribute and then cause people to do violent things. So my question would be, is it the issue of guns themselves, and again, I'm not discounting anything that you said, especially in terms of the research that you've brought up, the 30 years of data that you mentioned. Is it guns themselves, or is it socio-cultural, environmental factors that then cause people to be in a particular state of mind to then choose to use a gun to commit violence? And you all are the experts, so you all clearly understand the question that I'm asking, so I'm repeating it not for you all, just for the general room. My concern would be if we focus our attention and efforts on the front end, the gun, as opposed to the socio-cultural, environmental factors that may push someone into that condition. Again, a poor economic environment, bad general government policy that locked people down in the case of a pandemic, or just simply not having any options or resources, and so that it leads people to this particular outcome. So again, you all understand this stuff in terms of how you study it.
Yeah.
But that's my general question.
So we did see, I'm just gathering information from the National Violent Death Reporting System in the states that are, and it's the whole nation and territories at this point. We all pretty much universally saw an increase in homicides, which in Kentucky in 2004 we didn't go above 200 homicides. We were pretty steady about 180, 190 for decades, and then all of a sudden we started to see an increase in 2015, but 2020 we saw a substantial increase, and it hasn't returned down. And a lot of the other states have seen the same. The suicides have kind of remained the same, but the homicides, the level of anger and aggression and assault, those sorts of issues have increased.
Thank you.
Did that answer your question?
Yes, ma'am, to a degree, but I think you got an answer as well, so I want to withhold my comment.
Yeah, I mean, I'm just gonna say that I don't think it's to that an either or a both and. I think that the weapon of choice is the gun, so there lies an issue there, even if an unused gun is no problem. And so I think that's why she's attempting to stay away from whether or not we're trying to legislate whether or not people have guns, but identify the circumstances that surround what makes it more likely for a weapon to be used in that way, and then you build policy and strategy based on what you learn from the data that we're able to collect, but also too, what makes this a grand idea is the fact that we don't know what we don't know. There are so many people that collect so many different things, and kind of having a data warehouse that kind of tells us everything that we can know with what we have relative to the gun and how it's used in these various capacities could then lead us in how we're determining legislation after that. But I don't think you could talk about one without the other, because I mean, the issue is the interconnectivity of the weapon and the kind of social and economic conditions when you kind of put them together.
Thank you. Thank you, Madam Chair.
Thank you. And our last question is Ms. Drake.
Thank you so much, and thank you, Dr. Brown, for all of your statistics. And I was similar to Dr. Olenka. I was curious about, because it seems like you have a lot of data already, and you've been collecting it for years. Mm-hmm. And Dr. Williams had mentioned a lot of other issues like trauma, and you all know I'm always focused on race. And how those things impact gun injury, gun violence. So will all of these things be housed in this office? And so you will have your data because you have data already. So I'm curious about, and then what? Once you house all these things, and how will you deal with things that you mentioned that we know are impacting?
Well, from my perspective, so we have a point to start with. We already have an established data set, but there are so many other factors, psychosocial factors that we need to link to the data. Mm-hmm. We need to link emergency department runs. We need to link, food deserts, all sorts of health disparity, everything. And when there's trauma, what services are available, and how do you get the services? How do you teach someone? There are things that you can do to get better, just the whole educating somebody about how they can heal from that. But yeah, it'll all be, we have a focus point, and then we will broaden that for better understanding.
Thank you.
And I'll also add that when I was doing research to create this office, I had no idea that KIPRIC existed. And so I was very excited when I learned that there is already an entity, an institution that we know as legislators that is trusted, who's already collecting this data. And so I just want folks to really get and understand that this office will just be part of that ecosystem of figuring out what are the best solutions for us to move forward as a state to ensure that we are decreasing gun violence in general, but also that we're identifying and understanding those root causes of violence. And this office is only to fill in the gap. And so we're not going to be able to do this without everyone working together. So whether that is folks who are informed about housing, law enforcement, mental health, the school system, this office would collaborate and work with all of those institutions to ensure that we're doing the right thing to make sure that people have their needs met, and that all of these systems are creating policies and practices and programs to ensure that we are decreasing the possibilities of gun violence that we're seeing across the state.
And I believe that my co-chair has a quick comment.
So well done. Great presentation. And I want to go back to something that you said very eloquently, and much more eloquently than I can say. A very profound thing, though, because it crosses not just through this issue, but through so many difficult issues that we deal with in this commission and in other places. You eloquently stated that this is complex, multifaceted, and it's not going to have a single answer that's going to solve the problem. That's something we all want to rush and grab and say, boom, here's the solution. And I'm not indicating that you said this was the solution to the problem, but I think we all need to be mindful, very mindful of what you challenged us to do, which is be persistent, be patient, not too patient, push hard, but plan to play the long game, because these sorts of challenges are going to take a long game effort. So thank you for all three of you, for your work and your testimony. But that statement struck me. So thank you.
I have a quick question before we wrap up and move on to our next one. But Representative Huron, I would like to continue a conversation of just my brain's going, I need to process it. And then I would love to continue a conversation with this. And I believe my question is for Dr. Brown. With the data that you've talked about with the number of homicides and suicides, do you have correlations of what those homicides came from?
The precipitating circumstances?
Yeah.
Yes, we do. And we're seeing an escalation of gang activity.
That was my next
Yep.
question. Yeah, that was, and I think, kind of to Dr. Berg's point too, I think one of the biggest fights that we have in Frankfort is urban versus rural, because we all look at things very differently. What gun violence is in Grayson County, like with the Junior Pro incident that Representative Herron brought up, is very different than the gang violence going on in Louisville. And I really hope with the recent election that the mayor will have that conversation, and Louisville leadership will start talking about these issues that are very real to the people in the West End and how that affects everyone. Louisville is our economic driver of the Commonwealth of Kentucky. There is no doubt about that. And so I look forward to continuing having those conversations and seeing what we can do to better that. But to Dr. Oleka's point, and several, I think Ms. Drake mentioned it as well, is the root causes of these things. And mental health is that. I truly believe is it's a bigger conversation we've got to start having as a General Assembly. I think COVID really brought that out, how mental health is very real. And I'm intrigued to continue the conversation about suicide, because suicide can happen by many measures. And just as Representative Herron said, I've been affected by suicide from a very close family friend. She did not shoot herself, but there are many measures that you can take to do that. And once you've made that decision, you're going to continue to try. And so just seeing what kind of continued conversation we can have with that. And so thank you all. This is a tough conversation, but you all gave great data. And so I appreciate that. Very well thought out presentation. So thank you. Next up on our agenda, we are going to invite Tracy Pulley with the Fulton County Access to Healthcare. And as a reminder, when you come to the table, please make sure to introduce yourself and speak into the microphone.
Hello, everyone. I'm Tracy Pulley.
Make sure the light is bright green.
Okay. Hi, I'm Tracy Pulley, and I am the Family Resource Youth Service Center Coordinator at Fulton Independent in Fulton County. And I appreciate a moment for the rural folks, and I think I'll be your shortest presentation. Thank you so much for your time, and thank you to Representative Rudy. I think I bugged him enough times asking about this commission and when they were going to take a look at Fulton that he got me on the agenda. So I'm from Fulton. I have not lived there all of my life. My grandparents moved there for work. My papa worked on the Illinois Central Railroad. Fulton is kind of a railroad town, and Hickman, to our west, the other town in the county, is a Mississippi River town. My dad was in the Air Force, so I was raised in multiple places. But when I graduated from the University of Florida, I realized I did not want to live in Miami. So that's how I ended up in Fulton. I asked just for the one map to be shown to you all because I don't have a PowerPoint presentation, but I just wanted to illustrate that Fulton is all the way over at the southwestern corner of Kentucky, and we're on the Missouri and the Tennessee state lines, so we're sort of isolated, but it's a really unique community. We're on the Mississippi River. We have I-69 running through. The railroad used to be Illinois Central, and now it's Canadian National. It's busy 24/7. So Fulton is often grouped with the river counties. They call us the 4 river counties. But Fulton doesn't match Ballard or Carlisle or Hickman. Fulton is sort of metropolitan. We have a Walmart and we have a McDonald's. We have your basics, yeah. But we're also different in terms of our economics and our racial makeup. So say, example, for our household income, it's about $31,000. So we're ranked 112 out of the 120 counties. Well, our 3 buddies next to us, they are 73, 67, and 47. So they're far away from us, about 50 counties different, even though we're neighbors. Our poverty rate is 25%, so we're number 16 in the state. And our neighbor Hickman is 62. Carlisle is 66, and Ballard is 86. So it just feels like, although Fulton is grouped with these other counties, that we just don't, thank you, that we don't match them. You really have to go all the way across the state, all the way over to the Appalachian counties to see who matches us economically. And then in terms of racial makeup, we don't match anyone until you get over to Christian County. So Fulton has 24% Black residents, and Christian has 22, and so does Jefferson. So we're unique. We're an interesting little county. So when I heard last year that you all had created a commission on race and access to opportunity, I was very excited because Fulton, in terms of our, real estate, they say location, location, location. We're a really good location. It feels like Fulton should be thriving. We do have a good amount of business. We have a distillery down in Hickman that's booming right now. We have a new dairy farm apparently that's relocating from California to us. But we still our folks, all of us who live there, we are doing very poorly in terms of our economics and our health care. So the latest county health rankings came out, and it turned out we dropped 17 points, and we are now in the bottom 5. So the other 4 counties, again, we get grouped, but we don't really match anybody else because the other 4 counties are all over in Appalachia. So I just thought this commission is about access to opportunity. And can you all help us figure out how to connect Fulton better with some access? I did this first time I've ever spoken in Frankfort, and I was very stressed about it. Brandon and Brett were helpful. But I realized finally I don't have to be a historian who knows everything about the county. I just have to tell you all what I know. So I will tell you that Fulton County grew more cotton than any of the other counties in the state. And I guess the Mississippi River floods the Hickman area regularly, so we have more fertile soil. And of course, as we know, slavery and cotton farming went hand in hand in America. I couldn't find any numbers of. I just heard a story this morning on NPR about how in Germany they do such a wonderful job of memorializing the Holocaust and what occurred there. But in America, not so much here about our memorializing of what went on during slavery. I did find that we had the highest number of lynchings in Fulton County in the 1800s. So there's just some racial history to our community that's unique. In terms of but I know I'm here to talk to you all about healthcare today, but race and economics, they just go hand in hand. And you all can see on the state map that we're in the corner. So we have to go east northeast for anything in terms of healthcare, because we're on the Tennessee state line. So all of our folks with medical cards, that's about 47% of our county, they can't cross the state line normally to see a physician. So that really isolates us as well. We did have a lovely little hospital, Parkway Regional, but then it was purchased by a company called Community Health Systems, which is now being investigated. There's a class fraud lawsuit against CHS because apparently what it did was it bought our hospital, and then it also owned the Martin, Tennessee hospital across the state line. And so they closed us so they wouldn't have the competition. So they're gone, but it hurt us greatly. And it also hurt us because not only did they own the hospital, they owned a great little clinic in Fulton called Hillview. And this is what I would love for Kentucky legislators to look at. They closed that clinic on the Kentucky side, and they reopened it on the South Fulton, Tennessee side. So I know I appreciated Senator Givens saying long view and lots of issues, because I know I'm talking about lots of different things, and I know there are no simple solutions. But I really would appreciate you all looking at border communities like us and what are the law differences between Kentucky and Tennessee that make us struggle in these areas. So Hickman residents who live 18 miles to the west of Fulton, so Fulton has the interstate and the railroad, and Hickman has the river. We're 18 miles apart, and they have to drive over to us if they want to use the health department. Their health department closed because of mold issues, so they have to come 18 miles east just to use the health department. And then, unfortunately, in my job, I am now seeing so many children with teeth problems that I'm crossing down into Tennessee, because Lake County, Tennessee, Reelfoot Lake, is the only county close to us that's as poor as us, and they have a place called Reelfoot Rural Ministries. And so, but I just hate that I'm going over to Tennessee to get medical care for our families. Unfortunately, you all know, I'm sure there have been presentations on dental problems, but dentists are not taking new patients anymore with medical cards. I've heard the reimbursement rate for dental x-rays is $7. And then, so anyway, I can't find any dentists who will help out our kiddos at this point. The closest one is the Benton Clinic. It's about an hour from us, and I'm grateful that it exists, but it's overloaded, and you can't always get in, and they don't do sedation dentistry. So really the closest sedation dentistry to us that takes medical cards is in Lexington, the UK Dental Clinic, which is, it took me 4 hours to drive here this morning. So if you don't have reliable transportation, that can be a major barrier. I'm not going to list all the health statistics for Fulton. Of course, you all have those at countyhealthrankings.org. But the fact that we are now in the bottom 5 in Kentucky, when all the rest of the counties with those struggles are far away from us, it just should be looked at if possible. You all passed Senate Bill 10 and created this commission because you recognize that race still impacts opportunity in America. In Fulton, our residents' access to opportunity keeps shrinking. Is it because we have the highest percentage of Black residents? I don't know, but I do know this commission can change things for Fulton. We need better access to health care. They did advise, my advisor said I should probably ask you all for something concrete. I'm not sure. I would love to ask that the commission somehow create a policy that Fulton be used as a pilot project for a new dental clinic. I know that Appalachian counties are able to team up together and use their collective voice to ask for things like that. So I don't know. Fulton only has about 6,000 residents. It may not be possible that could happen, but we do have a wonderful new opportunity with the federal government. They've created the Rural Partners Network, and Fulton is included in that, and so that's supposed to put us at the top of the list for federal grant opportunities. So I don't know if that's something that could is something the commission could help us with. We do have another wonderful program that's starting a doctor who grew up in poverty and now is giving back, is coming to our schools. We have a school at Fulton Independent in the town of Fulton, and then Fulton County in the town of Hickman. And he is coming to our schools now one Friday a month and providing physicals and basic things like that. So the woman, Diane Owen, who's with Robbie Rudolph's Four Rivers Foundation, she wrote that grant, and I talked to her, and you should ask for equipped medical clinics at both school districts, because then right now he's like an art teacher with a cart just kind of rolling around, whereas if he had an equipped clinic, he could really provide some more significant health services. So I know those are big asks. I have no idea if that's in your capacity, but I thank you all for giving a moment to Fulton County to have us be heard. I apologize that I am a white lady coming and speaking for Fulton about our racial, economic, and health care needs. I did have a friend, Benita Cheers, who's our 4-H agent, and she was going to come with me, and then we had a conflict with the October date, and so she couldn't come today. So again, I've been there with the district for 18 years, and I could possibly answer some questions about our issues, but if I can't, I'd be happy to try to do some research for you.
Thank you, Tracy. Thank you for your engagement on this issue. I've traveled to Fulton, and there are a lot of disparities there, and you can tell it's a community that at one point it was very big, and it's just kind of it's dwindled away. So I will pass it over to my co-chair, Senator Givens, who I believe has a question.
So thanks for traveling 4 hours.
Thank you.
And thanks for your passion for your community, your love for what you do there and for the people there. And it's going to take champions like you to keep carrying that torch. So kudos to you for doing that.
Thank you.
You actually answered my question in the midst of the latter part of your presentation, because I was marking what I thought you wanted us to know and what you wanted us to take away. And so you wanted to put Fulton County on the map, literally and figuratively both. You wanted us to know about the struggles. Mm-hmm. My question was going to be, when we leave today, what are the one or two things that you want us to be thinking about? And you very specifically indicated a Fulton County pilot project related to dental care.
Yes.
I would encourage you to follow up with your elected representative and your elected senator and the members of this commission with a letter indicating the typical flowery language we all use at the start of what a joy it is to appear in front of you, blah, blah, blah. Remind us of your ask in a very pointed way.
Okay.
And continue to be a champion. Thank you.
Thank you so much.
Are there any other questions? Senator Neal?
First of all, thank you very much for coming and presenting. I had to step out for a minute. I apologize to you for that. You may have covered this. Your public health, there's a public health coordinator in that county, correct?
So we have the Purchase District Health Department that oversees our health department.
It's regional.
In Fulton. Yes. Yeah,
Okay.
it's regional.
That's okay. I can do that work. That's okay. I'll just stop right there. I need to do a little homework. Thank you very much.
Kent Coster is our director of that.
Thank you so much.
Dr. Oleka?
Thank you, Madam Chair. Thank you for the presentation and for driving for so long. I want to echo what Chairman Givens was saying in terms of the request for us as a commission, and I don't want to overburden us, and this may not be our job, but I know that there are certain grants that are available for health, basically the different types of disparities that the commission covers. I don't know if it would be useful for us to put those somewhere or try to organize or aggregate those so that folks who are interested in some type of grant or some type of support financially can have an easy access to that based on what this commission does. For you, a couple questions to that note. Do you know if there is specifically an opioid issue in your community? I'm not making the assumption, but there's a grant opportunity that could follow up with that.
Oh, great. Well, so I started the ASAP Council. When I came back to the job in 2009, I found out that we were one of only 6 counties that didn't have an ASAP Council on that. So we've got that going. But actually, no, even though there's tons of opioid funding out there, and I'm on an opioid task force that runs out of Paducah, it's still meth that's our number one issue.
Okay.
For a long time, we had the highest liquor store density in Kentucky, but that's diminished over time. Yeah.
My second question, I know that we've got the ad districts that are all around the state. One of the things that a number of different communities have done, and I don't know if the judge executives in the area work together or communicate at all, so I don't want to make any assumptions one way or the other. One thing that's been useful that I've seen is that different communities, different judge executives have tried to pull together some resources for some regional opportunities. And I only know this because I worked in the treasurer's office in Kentucky. In Ohio, they have a Star Ohio program. It's a state treasurer's asset reserves program. Long story short, what they do is they help local municipalities pool together resources that may not have them on their own to try to develop a deeper sense of capital so they could build a new regional hospital, or they could build some different resources that could impact the community. You're mentioning going down to Tennessee. If some of the things that Fulton needs are in Fulton because of a regional push to pool those resources, that could be beneficial. So what I might offer to you is again, asking your elected officials, your local folks, do you all work together in a regional sense for some of the same needs that might exist in the broader community? I think that could be helpful as well.
Yeah, about collaborating. Okay, thank you.
Thank you.
Thank you very much.
Thank you.
Oh, sorry. Just the last. What I have to say though is, I feel like regional agencies take Fulton's numbers, they take our high need, and they write grants, and then they just don't come down and serve us very much. They use their regional, but yeah, I'll talk to our judge executive. Thank you.
Thank you very much, Tracy. We appreciate you. Thanks for making the drive to Frankfort.
Thank you.
And our last presentation is the Kentucky Demographics Update from Kentucky Center for Statistics. Now, you have got a wonderful presentation with lots of great data. I can give you 9 minutes to speak. Both Senator Givens and I have 1 o'clock meetings. No, Killian. No. Okay, what's your question? You get 2 seconds. Okay. These people, they're needy up here, man. Okay, so if you'll introduce yourself for the record and give us a presentation. Now, I do want to offer, there's been a long agenda, and that is our fault. But we would, we want to hear as much as you have to say in a short time span. Allow us to answer, to ask a few questions. And then we would like to go in and extend an invitation for you to be our first speaker during the next interim in 2023 as well, because I know we requested this information, and I know you've got lots of good data to give us. Now, Representative Timoney, what kind of question would you have after, or what kind of question would you have? Well, first, if you'll introduce yourself for the record, that'd be fantastic.
Sure, thank you. My name is Dr. Matt Berry. I am the Research Director for the Kentucky Center for Statistics, or KY Stats, and I can be shockingly fast with this amount of data, but I know we have a question.
Quick.
Population change in Kentucky. Broken down into categories. What are we seeing? What trends are there? Are we growing? Because I think as a Commonwealth, we need to show growth in order to reach our goals. But
So good question. Thank you. It actually, I have an answer to that on one of my very first slides. So if you don't, or close enough to an answer. So I will answer it first, but let me say very quickly that I appreciate the acknowledgement that we have a very short amount of time. I'm aware of that also. We will take you up on the invitation to come back next year. We appreciate that. So what I was going to say anyway is that this is intended to be an overview. It's a state level overview of our demographics. At the Kentucky at KY Stats, we have one of the richest data sets in the country. We're very lucky. So we can do a lot more than what you see here. So I wanted to acknowledge that, and then also encourage you all to ask us really hard questions that you may not see answers to today, because we want to be doing more. So I will give you an answer. Let me get to that on the next slide. I think if I have just a few minutes, I want to show you some sort of 4 key trends that we've noticed. What we've done here is two major things in this presentation. One is we've tried to take a look at the racial demographics in the state in key sectors of the state. We look at K-12 education, post-secondary education, the population in general, the workforce. And we tried to, when possible, look over time. And so we looked at about a 10-year period when possible. Sometimes it wasn't possible, and you can see that in the slides that we've provided for you all. But the 4 key trends that I think we want to highlight are, number one, Kentucky's population, white population, is decreasing, so we're becoming more racially diverse as a state over a 10-year period. Our K-12 enrollment for non-white students similarly is increasing, so again, becoming more diverse racially. Our post-secondary enrollment, while it's going down in general in recent years, it's increasing for certain demographic groups, racial groups, Asian, Hispanic, Latino, and those who identify as 2 or more races. And then finally, the Black, Asian, and multiracial workforces are all increasing in terms of their labor force participation rates. So I wanted to mention those 4 things with the limited time we do have, just to say that those are some key trends that we noticed in the data that we analyzed. Now, in terms of our population in general, what we do have here today, and I can follow up with you on a particular number at the state level population, just sort of the raw top level number. But in terms of our racial makeup, what you can see is, related to the first bullet point that I just mentioned, is that we are becoming more racially diverse as a state. So these are census numbers between 2010 and 2020, so a 10-year window. You can see that in 2010, the state was about 86% white population, and then in 2020, the most recent data available, we're about just over 81%. So that's a 5-point decrease. And you can see all of the other primary racial demographic groups, which are reported in the census, have increased in that time. Some just slightly. Our Black population has gone up, less than a percentage point, but other populations such as Hispanic or Latino, and in particular our 2 or more races populations, have gone up even more significantly. So what I would say to your question is that the growth that we're seeing is in sort of the non-white population. That's demographically speaking, and then we'll have to follow up with you on sort of the general population number itself, and we will do that. And so I do want to touch on this as well. This is sort of an overwhelming slide, I know, but the takeaway here is the driver, I think, of this diversification racially is occurring in our younger demographics, right? And so this is a slide looking at our youth population, 0 to 19 years of age. The key takeaway here is we have these bucketed from 0 to 4 years, 5 to 9, 10, 14, 15 to 19. The yellow bars there show the percentage of each of those populations, again, 2020 to 2010, that identify as white. In each of the cases, these age buckets have become more racially diverse, or a lower percentage of those buckets are identified as white. And so the state as a whole is becoming more racially diverse, but these are really the population groups that are driving that. What I think probably makes sense just off the top of your head, if you hear that, is that the K-12 demographics are similarly shifting. So this is kind of just an overview of the percentages of our K-12 public school enrollment, and then this is a view over time. This is very, very similar to the demographic shift in general that we showed, in that between these periods, this almost 10-year period, we have one group which has decreased in terms of its percentage of the whole, and that's the white population in terms of K-12 public enrollment. I'm just going to highlight a couple of other pieces, and I apologize for skipping through some of these, but I do want to have the hope for at least 1 or 2 questions if possible. So I mentioned earlier as one of our key takeaways that our post-secondary enrollment has decreased. So you can see in about 10 years, the total post-secondary enrollment, and this is all levels I should mention, so this is undergrad all the way through the higher levels. Enrollment's gone down about 260,000 to just shy of 250,000. The percentage of enrollment, which are students identified as white, has gone down, I think, relatively significantly. Our Black population, as a percentage of enrollment, has gone down less significantly, but still down, and all other groups have increased during that time. I do want to say though that I do want to mention while the enrollment has gone down, degree completions or degree completers, have gone up. So we have fewer people enrolling. We do have more people completing degrees. And in this case, all racial and demographic groups have similarly increased. I'll just touch on labor force participation rates relatively quickly. You can see in this period here, or between these two periods, it is about the same for the state. Between the two periods, you see slight drop there, but it's basically a 59.5% labor force participation rate. That's 16 years of age and up. And then because the rate itself is similar, the demographic groups are basically stable also across the board. We did drill into, and this is something that I think I would offer that we could speak more about when we do have the opportunity to come speak to you again. We drilled into one particular piece of the teacher workforce. The takeaway here is that there are kind of two takeaways here. Again, without having to get too deep into this, the predominant share of our teaching workforce identify as white, and so if you think back to the earlier slides in terms of K-12 public enrollment in our youth populations becoming more racially diverse, what that really ends up meaning is in the classroom, students are far more likely to be consider themselves non-white than their students are. And you can see that's about students are about 3 times more likely to be black than their teachers, 8.5 times more likely to be Hispanic than their teachers, and about 51 times more likely to be 2 or more races than their teachers. And so again, we just wanted to highlight, what we consider, and we know that as being considered a key piece of our workforce right now. And I just want to highlight a couple of more. This is our median income, 2015 to 2020. For all racial and demographic groups, the median income has increased. The largest increase is for our black population, up 28%, although still in terms of raw income, the lowest group. And then the smallest increase is about 7%. And finally, our inmate population. This is again another 10-year look. The one population, so the total inmate population here in Kentucky has decreased during this time. The one population that has decreased in terms of a percentage of the total inmates is our black population, down about 3 points in that 10-year period. And then this is a summary which I think just kind of digs a little more into the sort of the 4 large bullet points that I gave you at the very beginning. So I won't take time to dig into these anymore, but I will leave before I ask if there are any questions in the limited time we have left. I will leave with more encouragement just to say that this is intended to be a very brief overview of our demographics as a state. And I think it just scratches the surface of what we're able to do as an agency. So what we've tried to do here is represent some of the opportunities that we have to provide more data and more analysis for you all as you continue your important work. So I really do want to encourage an ongoing conversation, and I do appreciate the opportunity or the invitation, to come back next year.
Okay, we're going to be very quick on our questions, and I'm actually going to give the opportunity for Senator Neal to briefly make a remark, and then I'm going to, just because of time, I'm going to ask that if any members were to have additional questions. Are you sure? Okay, thanks, Senator Neal. You're officially my favorite.
Let me be your unfavorite.
Oh, man. Senator Givens, always my unfavorite.
Senator, my co-chair has to get to a committee, and I'm not going to be long, but share briefly with the group, because you do have such rich data. You're an underappreciated asset here in Kentucky. You're an evolution of the old KSUS model. Walk this group in 30 seconds through what you can do for us that we just don't know.
Great. Thank you for that prompt. I should have done that. I usually do that little sales pitch at the beginning, but I skipped it. So thank you for that. So we are the Kentucky Center for Statistics is what's known as the State Longitudinal Data System. This is for folks who may not be familiar. And what that really means is we have data from agencies and partners across the state, from early childhood education to K-12 education, post-secondary, workforce, and so on and so on and so on. We're able to connect those data across those systems to understand how individuals and outcomes move through those systems, and we're able to connect it over time. And so if we provide analyses, many of our data systems go back more than 10 years. And so we can ask questions about how a K-12 environment may impact post-secondary enrollment, which may impact workforce outcomes, which may impact health outcomes and so on and so forth. And we can do it over time, and we can do it, regionally, demographically, at the state level. And so we have all kinds of opportunities. I agree with you. We're an underutilized resource. We work every day to try to rectify that, but we could always use more. I do want to, if I apologize, this isn't your question, Senator Givens, but Representative Timoney, I got a note from my colleague. Thank goodness she was here. The population for Kentucky did increase between 2010 and 2020 slightly, from about 4.3 million to about 4.5 million total residents.
Thank you. And Senator Berg, please send your question to Brandon so he can relay it, and then we will make sure to get an answer back to you. I apologize for being rude. Thank you very much.
Not at all. Thank you very much.
We greatly appreciate it. Just to wrap up this final meeting, Dr. Oleka has sent in a resignation letter effective November 30th.
Not accepted.
We wish him the best, thank him for his service, and if we had more time, I would say thank you for creating this commission, but unfortunately we do not. Just teasing. Thank you for your hard work on this, Dr. Oleka, and for allowing Senator Givens and I to bring your vision as policymakers to the General Assembly, and I'm glad that you were able to see the fruits of your labor in making the Commonwealth a better place. Best of luck in whatever you decide to do from here. There's a letter from the finance regarding requests for data on minority contracts issued. If you have any questions about that, please reach out to Brandon and he will make sure to get that to us. Unfortunately, we do not have time to discuss any legislation that we'll be doing in the 2023 session, but Senator Givens and I welcome each member. If we can be helpful, please reach out to us and let us know what legislation you're interested in pushing. But Brandon will send out a list of recommendations that we've kind of talked about this interim. He'll send that to each of us, and feel free, our offices are open to have further conversations on that. And then, of course, any of the legislative members on the task force, please let staff know if you'd like to request any legislation individually that pertains to the mission of the commission. Thank you all for the opportunity to once again serve. As always, I enjoy my time with each of you all. So thank you. Motion to adjourn.
So moved. Second.
Meeting adjourned.